So, hi everyone. It's my pleasure to be the first talk of today from Munich, actually. So, it's also very nice to hear that you will be coming here. It's very rainy and dark right now. So, not as much positive things I can tell about Munich as you did from the area. My goal today is to both talk about our very recent work from NeurIP, EgoExOR, but also to give the audience that's probably not very familiar with AI in surgery a general feel for what is possible there. So this work, the focus of our work here was Ego-Exo-Centric operating room, creating this data set to allow recognition of surgical activities. But you might be asking yourself, why is this even needed? So to allow me to tell that story a bit better, I want to first introduce you to surgical data science, which is probably a term that you're not very familiar with. Uh, Basically, over the last 100, 200 years, maybe even more, the surgery has evolved from a very rudimentary discipline that looked honestly more like a butchery than a science into what it is today, where the surgeons are getting trained 10 plus years on even very specific cases, and it requires a high level of time to really be an expert in this domain. And you need to consider a lot of different things. There are imaging modalities, there are a lot of high-end medical devices, there's domain knowledge, there's this case knowledge and the patient individual data. And this is actually not getting even easier over time. And in the future, we believe that this will increase more and more. There will be even more complexity in performing a good surgery. And this is overall not a bad thing because we are seeing overall much better patient outcomes. So the safety is getting improved. The patients are more likely to have just less pain and just overall have a better life afterwards. The more illnesses are becoming treatable. However, the downside is the general complexity is getting higher and higher, and more training is required over the years. And this is where we believe surgical data science will play a huge role. The definition of it is basically the goal here is to improve the quality of the interventional healthcare. And the method is very simple. We need to capture as much as possible from the surgical field. This starts from medical records, goes to images, sensors, real-time captures from cameras, and so on, and processing, analyzing, modeling all of this data to be able to create smart systems that can, let's say, predict different events, clinical outcomes, and assist the clinicians, physicians in decision making, and so on. Just a warning, it will be a bit of graphic content, and I will be showing if you're not used to it. I got used to it, but I know that these scenes can be a bit overwhelming. So just a heads up there. And the question I'm asking here is basically, do we have any digital system that can understand this? And I've been asking this kind of a question since 4 years now, and clearly the answer has turned from absolutely no to maybe. It is still, if you are thinking of your favorite large language model, it is still quite outside of their expertise to fundamentally understand these scenes, but we are definitely making some progress here. When we talk about holistic operating room understanding, we really think about understanding everything, so every signal, every input modality, and bringing all together to enable a lot of different systems like decision support, context-aware intelligence systems, different types of automations of robotic systems, and other medical devices. And specifically now, when we come back from this background to our recent work, EgoExOR, our motivation was clear. We understand that operating rooms are very dynamic, very crowded, and very safety critical. These are generally very complex environments. And we noticed that a lot of gaps exist in the existing public data here. The prior OR data sets did not offer any first person or egocentric perspectives. And there was one single data set, and it was only from the surgeon's perspective without any other cameras. So we realized you fundamentally need to be able to see the surgery from the perspective of everybody, because everybody brings a unique viewpoint, as well as from the external perspectives, because you will never be able to cover everything just from the egocentric perspective. So therefore, we created EgoExOR, which kind of is, I would describe it as the best of both worlds in terms of the variability in the data. The recording environment consisted of two main sensors. One was the Meta area glasses. We are very happy that Meta was able to donate us 6 glasses for this project, as well as Azure Connect cameras. The Meta glasses, the area glasses were used to capture the unique egocentric perspective, and the external cameras of Azure were mounted on the ceiling to capture the external perspective. We had to decide what we want to film, what we want to record, and we decided on a realistic 2 procedures basically. The first one is the more, let's say, less painful procedure, the more easy procedure, which is ultrasound-guided needle insertion. This operation is usually done to relieve back pain. It's a very common procedure, and the workflow phases usually include stuff like preparing, sterilizing, guiding the needle towards the correct location using something like ultrasound or X-ray, then injecting the medication that relieves the back pain. And we not only recorded normal cases here, we also included certain complications like dropping the gauze, having the needle contaminated, and so on, just to create some variability. The second operation is called minimally invasive spine surgery. It's basically once you notice that a simple medication injected in the correct location does not relieve back pain, it might be necessary to go in there and perform a surgery, and in this case, a minimally invasive surgery. This includes, again, patient positioning, creating an incision, and creating an access at the correct location. Then certain decompression techniques using specialized instruments to relieve the pain in that area. And again, we have some complications like missing some instruments, microscope not being aligned correctly, and so on. This is all to create as much as possible realistic scenarios with some realistic complications. And this is how our filming setup basically looked like. You can see some examples of our external cameras, ultrasound recording, and so on. And if you have not seen so far, this is what an area glass, just one of them, gives you. Basically, it gives you an RGB perspective, it gives you eye tracking, it gives you SLAM cameras for a very accurate localization, it gives you audio and many other things. This is the result after processing basically from one camera. You don't only get RGB, you have semi-dense point cloud tracking, which also allows you to do kind of understand where the camera is in the 3D room all the time. And this is, again, just from the point of view of one camera, but we had 6 of them, so it really gives you a very comprehensive picture together. These are all the modalities that we ended up collecting in EgoExOR. So we have an RGB video from all the different participants in the surgery. We have then on top of that gaze and hand pose predictions that come from area, again for all the participants. We have ultrasound screen or the microscope screen recorded separately as a separate modality. Then we have the egocentric cameras that are, external cameras that are RGB-D, and this also allows us to have a point cloud at the end. And we have also audio, audio also per camera. So we know really who said what at which second. And we annotated all of these using scene graphs. And I assume some of the audience at least might not be familiar with scene graphs. So I have a video to share here to kind of motivate that. What you will see is basically scene graphs are not a new concept. They were actually used a lot for filmmaking. Basically, back in the day, you were describing how you wanted the scene to look like using a scene graph, using a kind of high-level description. And then this was semi-automatically getting converted into a movie. Either your animators were doing it manually or a program was doing it manually. And this video summarizes, I don't know if you can hear the audio or not. It's not, the audio is not very important. This audio kind of summarizes, maybe you have seen it before also, that many different film studios reused a certain animation, basically the semantics of it in a new light. So the lighting changes or the texture changes, but the fundamental part stays the same. Basically, animation stays the same. And we like to imagine basically that the scene graphs are the same, just how they are envisioned is different. And why it is, of course, very interesting for our case is, again, the surgery, the exact operating room, the exact surgical tools might look different, but the fundamental semantics stays the same across a lot of different surgeries, across operating rooms, and so on. So you want to work with a representation that is ambiguous to these potential changes. By the way, I'm seeing some chat comments. If you have any questions, feel free to interrupt me directly.
Yeah, we don't have any questions at this point.
Good. So the key steps of EgoExOR are these. Basically, it covers all the stages of the surgery from roll in to the roll out and everything in between. And I have a short video, sorry, short video basically demonstrating what we have captured. And I will let you watch it a bit to just get a feel for the data set. Here is an example of a deviation in the workflow. Here is, you can even see that we can really precise locate where the surgeon is looking on the ultrasound monitor and so on. Comes from the gaze annotations. Okay, cool. So to go along with this data set, we decided to basically also have a baseline, a scene graph generation baseline. And while this is not the main contribution of this paper, we decided that it makes sense to basically start from what is out there, but create something that really leverages this data set effectively. And to this end, we decided to create this two-branch architecture where we have this egocentric branch that focuses on all the external modalities that the previous scene graphs data set had, and also an egocentric branch that focuses on the new modalities like the ARIA glasses, the hand tracking, the eye gaze. These are all processed using different kinds of encoders like image encoders, hand pose encoder, gaze encoder, audio encoder, and so on. And they are all pulled together and brought together into one common large vision language model space, which then views all of this context at once and is able to reason about it and produce a scene graph, all end to end. And the results we saw were very encouraging. So if you look at the two different tables, basically the dual branch baseline is all able to outperform the existing state of the art by quite some margin. So we see that kind of being able to focus on both of these modalities is indeed very, very important. And the second ablation study, which was to us also very important, was to see if egocentric is indeed, as we argued, a very important modality that was really missing from the previous data sets. And our results basically show that quite well. In terms of, in comparison to only having access to the external cameras, the egocentric view is very, very helpful and is actually the more crucial modality. We also see that combining both of them leads to the best results, but I think our results support that egocentric is the more important modality and should be considered in future research in this direction. Here are some examples of what scene graphs ended up detecting or covering. So our scene graphs basically represent every object in the scene that is interesting as a node, like patient, cotton, operating table, health monitor, and so on. And the edges between them describe how this one object is interacting with another one. So assistant is assisting the patient is lying on the operating table, and so on. So these are all captured in the scene graph and can be then used for different downstream tasks. So this is basically a conclusion of this paper, and what we have seen is what we have done is basically introduce this first data set that has both egocentric and exocentric perspectives in surgical environments, which enable comprehensive activity understanding through multi-view scene graphs. And we have released all of this, both our code, the baseline, and of course the data set, and made it already publicly available. I will take a short break here. I'm also not quite aware of my time situation for questions. If there is time, I have some backup slides to talk about potential use cases of these in the future.